CT PET SPECT. Which test is best for diagnosis of ischemia?
So in principle, the important part is to either exclude coronary artery disease. That can be done in relatively low pretest likelihood very well with CT imaging. Or you want to exclude or prove myocardial ischemia. For that, you should use a test which looks directly at the myocardium with high spatial resolution. The best tests for that are PET imaging or, probably more in clinical routine now, CMR perfusion imaging.
And could we replace invasive testing by non-invasive strategies?
Increasingly, non-invasive strategies help us to avoid invasive testing, again, either by excluding disease, by proving whether there is ischemia or no ischemia, and by also slowly increasing the threshold for significance. So what we used to say with non-invasive imaging was to say if there's any ischemia, patients know to go to invasive angiography. What we now learn is that we have to actually have a sufficient amount of ischemia to actually have a benefit from revascularization. That amount is probably in the range of 10 to 12% ischemic myocardium, and by non-invasive testing, either looking for perfusion defects or looking for significant coronary artery stenosis by CT helps us to avoid invasive angiographies. When we add CT FFR, which means calculating the pressure difference through a stenosis with computational fluid dynamics, we can further improve the CT scanning by adding a functional component. Other tests such as PET or CMR perfusion imaging will look directly at the myocardium and by that directly see the amount of ischemia.
What is the endpoint of MRI Informed Trial and what are the results?
So in the MRI Informed Trial we randomized patients with a high pretest likelihood for coronary artery disease into either invasive guidance with invasive angiography plus FFR or into non-invasive guidance by MR perfusion imaging. The patients were then treated according to the results of their respective arms. So if they had a positive invasive angiography plus FFR, they were revascularized, otherwise they were put on optimal medical therapy. And similarly, in the MR-informed arm, if they had a positive MR, they were then sent to invasive angiography and revascularized. If the MR perfusion scan was negative, they were treated with optimal medical therapy. Patients were followed up for a year, and we looked for major cardiac events after a year. And importantly, the results between two arms are identical. So you can replace invasive angiography plus FFR with a non-invasive test, CMR perfusion imaging, and the guidance, the management of the patients is as safe as with the invasive procedure.
So we are looking at improving the test.
I think the tests are now at a point where we do not need to focus on technical improvement. We need to focus on management improvement, putting the right test into the management pathway of patients, providing accessibility to the scanner technology, to the software, to competent people. But if there is a will to organize this, there is now a means to do that, because the MR scanning technology is available in nearly every advanced hospital, and there are more and more people obviously able to do this technology. The test by itself is relatively simple, can be done in about 20 to 25 minutes and requires practice in interpretation, but again that can be learned with a reasonable amount of time.